So next we go on to our next eminent speaker is Dr. Colonel Deepak Mulajker, who is Associate Professor of Medicine and Medical Oncology, and is a colleague of mine at Army Hospital in Delhi. He has a keen interest in basic sciences and research, and he is also an academician and a clinician par excellence. He has done a lot of work on prostate cancer at our center, and he would be the ideal person to speak on the clinical implications of what Dr. Mehta has told us, that is HRR, in the management of castration-resistant prostate cancer. Dr. Deepak, please.
Thank you, sir. Am I audible and slides are visible?
Yes. Yes. Yeah.
Thank you so much. First of all, sir, it was a great lecture which was preceding mine. And after that lecture, I think this will be just a kind of a quite a, I won't be able to live up to those standards, but I'll anyway try. So presently, after having heard about HRR and HRD, so we'll now go on and see what are the clinical implications. For this, mostly I'm presenting to you the PROFOUND trial. Now, basically the epidemiology, all of you know about prostate cancers. Then we all know that mostly all the patients with metastatic prostate cancer at some point of time certainly go on to develop a castrate-resistant prostate cancer. And the overall median survival for these patients remains poor. So despite significant progress in systemic therapy, and we keep getting new molecules every day, the therapy seems to be inadequate at certain times. And in these cases where we find that 30% of patients harbor some alterations in DNA damage repair genes, including HRR genes. So these are the targetable lesions that we have come to know. We have seen this in ovarian cancers. We are seeing it in breast cancers. We are seeing now in prostate cancers. So we have two candidates here. We have rucaparib as well as olaparib. Presently, I'll take you through the PROFOUND trial once. And PROFOUND trial basically was a randomized open label trial, which was olaparib versus new hormonal agents according to the treatment choice. So the inclusion criteria were metastatic castrate-resistant prostate cancer. You had HRR mutation. This was done by Foundation One. They had tied up with Foundation guys, and probably they used that. As usual, the ECOG was PS 0 to 2, and they basically divided into two cohorts, cohort A and cohort B. Now, as we all know, there are about 15 genes, but the majority, as we have seen in the previous presentation, are BRCA2 followed by ATM, and then subsequently probably BRCA1. So these were the cohort 1 where the chances of getting a positivity were high, and the other genes that are involved in HRR were grouped into the cohort B. So basically, it was a 2:1 randomization with the olaparib versus physician's choice. Physician's choice could be either enzalutamide or abiraterone. People who had received abiraterone prior probably switched on to enzalutamide, and the otherwise. The number of people who had taken taxanes earlier was quite low in this, but nonetheless, there were a few patients who had taken a post-taxane therapy also. So there was a crossover in which the patients who had progressed on the physician's choice could go on to optional oraparib at progression. So the primary primary endpoint was a median progression-free survival by imaging modality. So, and the secondary endpoints, and there was a hierarchical design to it, that you had to first demonstrate a PFS benefit before you could go ahead and do the other secondary endpoints. So they went on to look for ORR. They then looked for time to pain progression, overall survival, and of course safety and tolerability of olaparib was also documented in this. So like I said, there were 15 genes, of which the cohort A was BRCA1, BRCA2, and ATM. The rest were all under cohort B. So Now, there was, before we go on to this, there was when we look at the patient characteristics in both the arms were more or less same between olaparib as well as the physician's choice, except that there were more visceral mets and in the physician choice group, as well as there were increased baseline PSA levels that was higher in the physician's choice group. Other than that, rest all were more or less together evenly balanced. So now Profound actually met its primary endpoint. And if we look at the two Kaplan-Meier things, we see that probably the graphs are quite nicely separating. And it had a median PFS as assessed by the imaging of about 7.39 months in olaparib compared to 3.55 in physician's choice arm.
Yeah, good evening, sir.
Pardon? Hello.
So Dr. A.P. Dubey is in Shanti Mukund Hospital, sir.
Pardon?
Hope you are getting, sir. Hello.
Hello, yes.
None, can you mute yourself? Sir, please continue, sir.
Okay. So we got a PFS, when they looked at the PFS, it met its primary endpoint. There was a hazard ratio of 0.34, that is, we had about 66% reduction in the hazard of progression, and the p-value was significant in this case. So if we looked at the subgroup analysis, again, more or less, all of them favored olaparib better than all, whether you had previous taxanes or no previous taxanes. But like I said, the number of patients in previous taxanes were quite low. And then bone only versus visceral only and other metastatic sites, age did not seem to matter. And probably the less number of ECOG2 in this reflects in the longer confidence interval that is visible. However, this study was not powered actually to kind of make the to demonstrate the differences between subgroups. Now, we come to the secondary key endpoints, and the first one was objective response rate. Objective response rate with olaparib was 33% compared to 2.3% with the physician's choice. And median time to brain progression, again, much better with olaparib compared to the physician's choice. When we go on to look at the OS benefit, now here the OS benefit, if you look at it, it's not actually reflected here. One of the major reasons that you can think of it is because probably the patients who were in physician's choice group could cross over into the olaparib group. So if we look at the median OS per se, according to this particular trial, and this thing I think was that maturity of somewhere around 30 to 40% of the data when this interim final OS had come out. And probably because of the crossover, we do not see any median OS benefit, which was statistically significant. You can say there is a trend towards median OS with 19 months versus 14 months. But if you look at the p-value, it is about 0.02. And at the confidence intervals, you look at 0.5 to 0.97. So now we come over for, these are like, I think I do not give much significance to this kind of analysis in which you try and see what would have happened had these patients not crossed over. Now, but yes, you can do that statistically. Most of the times you can play with statistics long enough and you get the results you want. But yes, if you adjust for crossover, then again you see that there is some benefit. There is a benefit, significant benefit in the OS also. Now, if we look at the patients, whether, again, we look at OS benefit, if we look at whether what are the patients who had benefited, you see more or less it is basically there is a benefit with olaparib, which is much better than the physician's choice. But low PSAs, probably there's it's crossing the line of unity. But again, like this wasn't powered to kind of bring out the differences between the subgroups. Now, this was 50% reduction. This was another PSA 50% reduction in PSA, again, greater with olaparib. Circulating tumor cell conversion. Now, this was a thing in which the circulating tumor cells were looked at whether they were more than 5 cells per 7.5 ml of blood. So if you look at whether it was from conversion from more than 5 to less than 5, again it is a little better with better with olaparib compared to physician's choice. So now we look at when we combine both the cohorts with cohort A as well as cohort B. So you find that there is median PFS is 5.82 with olaparib compared with the physician's choice of 3.52. You look that probably the cohort B has dragged down the median PFS when that was seen with cohort A. Probably tells you that the other HRR markers, this probably the olaparib was not as effective. So again, the same subgroup analysis, you put all of them together. So olaparib still does better. And if you look at objective response rate, again, you look at it, it was 33% when group A, and when you add group B to it, cohort B to it, you see that it is dragged down. However, the physician's choice seems to be remaining stable at the same for both of them. Again, this is a median time to pain progression. Again, we see that olaparib is doing better in when we look at it at cohort A. And cohort A, we must remember, looked at BRCA1, BRCA2, and ATM. PSA 50, again, with a complete population, it more or less it says olaparib is better. Now, if we look at median time to pain progression, again, this was with both the cohorts A and B, we find olaparib again better. But if we look at what are the therapies that people shifted onto, you find in physician's choice nearly about 60% of the patients subsequently went on to receive olaparib after they had progressed on the physician's choice. So this was the reason what you can give for why you don't have a significant OS benefit when you are looking at the final results. So again, we are looking at whether we do for BRCA1 cohort A, cohort B. If you look at it, progression of this median investigator assessed radiological PFS, in cohort A, it is about 9.7 versus 3.55, whereas cohort B, it's about 5.59 to 3.35. Not much difference there. And again, you can look at the confidence interval nearly reaching up to the unity. So based on this, probably the recommendation would probably be to go for a olaparib in case you only have a BRCA1, BRCA2, and or ATM positivity. As regards the other genes, there doesn't seem to be a very clear-cut benefit that we might be able to get from giving olaparib. So these are the same things, like I said, the treatment switch adjustment, and like I said, if you play along with statistics long enough, you will probably be able to get all these data. If we look at an important thing here was when you looked at them from the genetic point of view of regarding each mutation. What is to be noted that ATM did not seem to have got much benefit out of it. Look at BRCA, CDK12, and ATM. You look at it, the benefit between the ATM was in physician's choice versus olaparib was not much. Compare it to BRCA or CDK12. And as far as the others are concerned, the numbers are really quite low to make any kind of comment. You have 4 patients, 1 patient, 6, 4 patients, check 2, 7, and 5, and RAD5 54L had 3 and 2 patients on each arm. So probably it's not, and moreover, it wasn't, of course, powered to bring out this kind of differences. But then there is this nagging thought that probably only ATM mutated might not derive as much benefit from olaparib as BRCA2.
Deepak sir, sorry to interrupt, sir. Last minute to conclude, please.
Yeah, I'm good. So, like I said, I'll skip through all these slides because more of them are more or less repeating themselves. Now, coming to the adverse event profile, we find anemia and fatigue to be very high. In fact, if you look at only about all not just grade 3, grade 4, and if you look at all adverse events, fatigue was the main adverse event which was seen with olaparib compared to the placebo. And then you have anemia, you have nausea, and there were one death attributable to pulmonary thromboembolism. Whether it was due to olaparib is I don't think so, but then that is what the data says. With this, I would like to thank all of you for a patient hearing. Thank you so much.
Thank you, Dr. Deepak, for again a very wonderful talk. Though you had underestimated yourself, I think we are all happy to have a very lucid presentation on the bare facts of olaparib. The trial has been laid bare in front of us, and I think further on, both Dr. Mehta as well as Dr. Deepak have laid the facts in front of us.